Sweet.
Okay. Now let me play with the lights again. Okay. All right. Much to, I do believe in giving you forewarning of things, so let me forewarn you. Today I'm going to leave you go about 45 minutes early because I have to go to a meeting about the doctoral program. I don't feel too guilty because you usually wind up staying a little bit over, so this is payback. And on April 26th, and I will put this as an announcement for the course, so you don't have to worry about the rest who are not here, but let them hang in suspense because they're not here on time. But on April 26th, you will not have class. April 26th. All right? And use that time to study for the final. Of course, there'll only be 1 week after that, and then your reading days with the review on the 7th at 10 o'clock. I have not put all of these things on as an announcement yet because the rooms did not come through. One came through, the other is still questionable, but you'll have the review on the 2nd at 10 o'clock, and the exam will be on, you'll have the review on the 7th, and the exam will be on the 10th. And I'm hoping for this room so that you don't get too confused. But the 26th of April, we will not have class. All right? So that will be time you can use for the exam. Today, I'm going to move on to ethics. And we talked about the law last week. I emphasized that there are certain things you should know, very simple things, the difference between assault and battery, imprisonment. We didn't talk much about the Good Samaritan law. Almost all states have Good Samaritan laws, but they can get you in trouble. The Good Samaritan laws presume consent, and that's important for you to hear. They presume the person whose aid you're going to would want the aid. If you stop at an automobile accident and the person is conscious, you're always to ask the person, do you want the help, before you give it. Never jump into motion, regardless of how much you know. Or if you're an EMT, it doesn't matter. You have to ask the person. If the person does not want you to help, you just stay by the person until help gets there. It's a very treacherous area, and there have been professionals that have been sued, either because the person doesn't want help, and that is usually because something goes wrong, you don't do exactly the right thing, but there's assumed, presumptive assent. All right? That is underneath all the Good Samaritan laws. We talked also about laws whistleblower laws, we mentioned that. And whistleblowers, this is just by way of review, because we mentioned most of these last week. Whistleblowers have to go the official route. If they see something very egregious, very bad, very what they think is illegal, improper, happening in their workplace, you don't just run outside of the workplace and report the boss. That doesn't work. You have to go the channels of authority. You have to report to your supervisor. Go to the supervisor's supervisor, the supervisor's boss. Even put it in writing. And then, when you still see no response at all, and you feel that intervening or bringing in the government would be better than what's occurring, you do so. And your job is protected and your anonymity is protected. Although often, when they've had a person complaining for weeks or months to every boss around, and all of a sudden the state shows up with a documentation of this, they can begin to envision who blew the whistle. But your job is protected and your anonymity is protected. Go read in your book if you haven't already. There's the case of a nurse in Massachusetts, in Lowell. Wonderful man. I have met him many times, who blew the whistle. He worked in long-term care as a supervisor, and he saw things going on which really compromised the health care of the residents. He finally, after trying every angle he could to get it to the attention of people, no action at all. He went to the state, and he had hell to pay after that. He lost his job, his anonymity was sacrificed. Now you say, how can that be? The state protects you. The state did protect him. But the owners found out. There was a lot of bad press because of it. The press likes nothing more than a juicy story in this country. You know, everything gets to the front page. And there is no boss that can't get rid of you if he or she wants to. There's always a way. Give you the worst assignment, give you the worst days off, you grieve, and he was embroiled in layers of grievance. Finally, he just left. And he made his professional life somewhere else. Although when people know you're this type of adversarial person, it's very difficult, even if you were in the right, all right? So you have to be cautious about whistleblowing. And whistleblowing is when your organization is functioning contrary to the law or to regulations. It's not that you just don't like what they're doing. It has to be a documented offense. And you have to have the proof. And you have to believe if this is taken care of, the patients will be better off. All right, so we went over all of those definitions and situations last week. We talked about unprofessional conduct and said that it was a very loose term years ago. And in your book, you'll find the only definition I could really find, and in the law. But lately, the boards of nursing have been much more critical of practice. And maybe that's because they don't deal with it anymore. Who takes care of disciplinary actions with nurses in this state? If you're caught diverting drugs, now what diverting, it's also a criminal offense, but if you're caught sneaking pills out of the drug room, I won't go into how, because it's not that easy, but if you're caught with them in your pocket, and the boss or your supervisor calls the police, who else is notified about you? What? RAM, yes, exactly, RAM. The Board of Nursing knows about it, but it just runs past their consciousness. They don't deal with it. They immediately will send you to RAM. Even if your boss directly calls the Board of Nursing, this is pretty common today. They'll say, I have a nurse in the conference room who I'm sure was taking narcotics while on duty. They will immediately say, go to RAM. Give me the name, but the name is pro forma. It's not entered anywhere in your record. The nurse is referred to RAM, where there is a program established to help her recover or him recover from substance abuse. And the only exception to that are some nurses which you can find that have several offenses of the same type against them, like they never learn, and so it's a chronic offender. Then it will be referred directly into the Board of Nursing. They have a disciplinary committee that meets once a month. This came to be about 5 or 8 years ago. I don't know exactly. If you're interested, go into NJSNA, the New Jersey State Nurses Association.org, and click on RAM. It's across the top, and they'll give you the whole history of the program. Yeah?
The disciplinary board, is
Ramp,
The disciplinary board that you're talking about, where
everything in regard to licenses is state-specific because of states' rights. The Constitution of each state claims responsibility for health, education, and welfare. So the RAMP, the disciplinary program, mostly for substance abuses, is state-specific, and in New Jersey, it exists under the Institute for Nursing. And the Institute for Nursing is a sub-organization or a satellite organization of the New Jersey State Nurses Association. All right? And the disciplinary board, though, is part of the Board of Nursing. But they deal with very few, they meet once a month, but they deal with very few cases, only chronic offenders, and then lots of times they say send them to RAM. There are several circumstances that came together that created those units in this state. Number one, there was less money to do the work of licensing boards. They used to have many more staff. Now they're down, I think, to 3 staff down on Halsey Street. And additionally, it's become preferred by the profession to help our own rather than put them in jail. You understand? They didn't literally go to jail, but they were dealt with very harshly. Today, if you're sent to RAM, it is usual that your license will not be taken away, so you can continue to work. It's also usual that you're in the program maybe 2 years, and the program consists of daily call-ins for urine screening for narcotics. In other words, every morning when you get up, you take your baby aspirin, you take your vitamin, you brush your teeth, and you call Quest, which is a laboratory. You put in your code number, and it will say you have no need to come and have your test done today, or today is your day. And these people are usually called in twice a month, and they have to give an on-site urine sample. In other words, it's an observed urine sample. An employee of Quest goes in with them into the restroom, because there are all sorts of ways of substituting clean urine for dirty urine, all right? They can continue to work, but sometimes a case manager, which they each have, will request that they surrender their license for a short period of time. But most of the time they're permitted to work, but they're monitored. Whoever is their immediate supervisor at work has to, on a monthly basis, submit a report saying that this person is a good employee. There are different words, but in other words, what they're looking for, it's no judgment about whether you're taking drugs or not. It's a judgment about whether you're showing up on time for work, whether you're capable, whether you know what you're doing, and that monitor sends that in to RAMP. So that's the way the cases are handled. The program was set up for substance abuses, drugs, and narcotics. But it's more than that now. Because, I guess, RAMP has done a good job, all sorts of non-professional conduct offenders are sent. And you can look at that list that's on your slides and in your book. Things like poor documentation skills, unethical behavior with patients. All sorts of offenders are sent, but they usually wind up to be in the program for shorter periods of time. I would say 90 days. Another requirement of the RAMP people is that they attend a peer support group once a week. Come death or high water, you got to go once a week. And if you can't go to the group that is your, quote, home group, you find another one on the list. And the list is on that website, too. All right? I run one in the north of the state, but like Wednesday night, I had 6 other people there who were from all over the state, but they couldn't get there the week before, and they have to make up. So they came to mine, all right? But they were there for the one night. So it's, the other thing is you're required to, if you're a drug or alcohol offender, to attend 4 AA or Al-Anon meetings in a week. 4. And there's no one checking behind you on this. But spasmodically, your case manager will check. And somehow they know. They get the picture. But group, be it a peer support group or AA, according to the people who are in this program, are their lifeline. There are alcoholics in the program who haven't touched a drink in 10 years. Now you think, my gosh, do they still have a problem? Yeah, and they'll tell you. I'm an alcoholic, once an alcoholic, always an alcoholic. And they're very, even though they're at a ramp for a long time, they wouldn't have to do any of this. They faithfully go to their meetings. The meetings, their life revolves around these meetings. So that comes out to about 5 meetings a week.
So, are the meetings all nurses, or are there other?
The peer support groups are meetings which are established by RAMP. They're run by nurses. We tried to get psychiatric clinical specialists to run them, but it's not a therapy group. It's a group run by the people. But yes, it's for nurses, by nurses. And a lot of the discussion is, how do I get back into the workforce? Which are the ramp-friendly places? Because there are some employers in this state that are definitely hostile to any nurse that has had a substance abuse problem of any kind. But you get to know which ones are friendly and which ones are hateful to these nurses. So it's those type of things and they share their problems too, things that got them there. So if any of you are at any time interested in coming to a RAMP meeting, tell me. I'll ask the group, because it's their meeting, not mine or yours. I'll ask them and you can come. Usually in psychiatric nursing, students used to, I don't know if they still do, go to an AA meeting. It's fascinating. There is absolutely no shame on the part of any of the members. They own these groups, and they all have a common problem. And they share to help one another. So the peer group are nurses. The other groups, the other support groups, are everybody. From the president of a corporation to the street cleaner. All equal. And all aiming for sobriety. Okay? So, and that's the way nurses are disciplined. It's a disciplinary action, disciplined in New Jersey. New York is similar, a little variation, but many of the states, if you're caught diverting drugs, now you know what diverting is, taking them for your own use. particularly with drugs and alcohol and going on duty that way, they will take away your license. And in this state, it was for approximately 5 years. You were without a license. And you were reviewed by the disciplinary committee of the state board periodically to see if you could go back to work. What really boggles my mind, there is rarely a nurse that I have met in RAM that I wouldn't trust to take care of a member of my family, and that's saying a lot. And we've had a lot of experience with illness. I've rarely met one I wouldn't trust. And they are firmly committed to nursing. To go through this, to get your license back, because many of them have been suspended. It's better now. Many of them can work. Some can work but can't dispense narcotics. There are differences. But what they go through to be a nurse again is mind-boggling to me. I wonder if I would have the strength to go through this. They're a wonderful group. And where they have gotten jobs again, they're among the best employees that an agency can have. They always show up. They're good to patients. Out of my group, 4 of them have completed baccalaureates since they're in the program. They want to climb up the ladder in nursing. They don't want to stay where they are. Many of them have gotten certifications, and you know now from your reading you can get it with just an RN. There are certifications. Many of them go to work in psychiatry. That makes me laugh. I laugh to them too. Why are you going to psychiatry? Particularly the men. Have a lot of men in the program, and they are wonderful. Psychiatric nurses, they're certified now, but still it's hard to walk back into a job. And to me, that's the sign of a weak administrator. It's the administrator that doesn't want them, doesn't want to take a risk, and I'd like to tell them probably they have 10% of the nurses they're employing now who have substance abuse problems. But they're shrewd and they can hide it. 10% is the percent in the general public. We do not have more substance abuses than other fields, but it's just, it becomes visible because of access, particularly to drugs. All right? Any other questions about RAM for the situations that may cause you to lose your license? As I said, they're becoming much more stringent, picking up these things. And I think it's all folded into the new consumerism. We talked about this last week. People expect more of nurses today. We are moving forward rapidly with the baccalaureate. People know it. They're expecting more from nurses. They don't expect deadhead behavior. They expect you to be responsible, and where there is a mistake, it's being picked up. Charting, as I said, big thing. Ethical violations. And again, it's on your list. Situations where you absolutely ignore the patient's right to privacy. You ignore the patient's right to confidentiality and you share information. Now, I am sure this happens much more than the few people that are disciplined by the Board of Nursing. Nurses are under obligation to report one another if they see anyone violating the Practice Act. Giving treatments and not knowing really how the equipment works. Yeah.
Can you discuss with another nurse, if you're not understanding the situation with your patient, would that be a confidentiality?
You can always go to someone that knows more than you, like a clinical specialist. That's one of the questions I tell students to ask when they go for a job. Do you have advanced practice nurses here? Because they're the people you can go to with a practice issue. But you're going just to get guidance for your practice, and you can prove it. To chat about a patient when you're going to lunch or in the elevator, and I'm serious, this happens, you're sucked into it very innocently, can be a violation of HIPAA, of FOLA. FOLA is the other confidentiality law. Yeah. So you're better off to never talk about your patients once you're off the unit. Yes, there will be things you have to talk to a head nurse or even another colleague that you feel has taken care of more patients. Usually it's best not to even discuss the identity. I have this situation, this patient who won't give me permission to do this procedure. The procedure is vital and he really has to have it done. Have you ever had this happen to you? All right. But what you know by virtue of your role as someone's nurse should never leave your lips. Okay? Any other? Now remember, HIPAA does not take into account verbal, well, it does, and HIPAA is for electronic transfer of information. And there are other confidentiality laws for sharing things verbally. But I don't think anyone it's enough for you to know that it's a violation of the law in this country to give information about a person. Now that person can give information, and it is frequent that an employer will have an employee sign an exemption. I would be reticent to do any of this. The unions are out of their head about this, and I don't blame them, because an employer could use information about health to make decisions about keeping a person. If you knew a person had stage 4 cancer and was on chemotherapy regularly, would you give them a job? Now, you may say yes, but there's always that window you can crawl through to find a reason. Why? What does it mean? It means massive health bills. Your cost for health insurance for everyone goes up if you have one heavy user. So this is what unions are afraid of and why they're so opposed to giving information. All right, let's move on to ethics. Ethics is the companion of the law. I love these first two slides, their definition. Morality is behavior based on religion or social influence. It's what you learn in catechism or in, I guess, Hebrew school or Sunday school or through your family. What comes down to you? Through social influences and religion. It's very personal, and it has no business in nursing. Your papers are coming, about half of you got them, but one thing that I note when I read them, and they're read very carefully, a lot of you still don't get it. You have a right to your religious precepts, to what your church teaches you. Of course you have a right. But if you are very, very staunch in those beliefs, know it. That's all we're asking you. Know it. And know that your beliefs could influence what you do with a patient. Remember that? There was a question on the midterm exam. We're not asking you to change your beliefs. And we also know that you can't change those beliefs and that it's going to influence what you do with the patient. Maybe in an ever so slight way, but it's going to influence. So know yourself, and that's what used to come out of the HIP course when we had seminars, but certain people didn't think it was important for you to know yourself, just as long as you know what's in the book. I don't happen to believe that. The most helpful courses I had in undergraduate and graduate school were seminar courses where you were forced to look at yourself, and boy was that a shock. When I found out how others saw me, that was the biggest shock. I mean, you're just there, you're well-meaning, you think everyone thinks you're well-meaning. They don't. They pick up reflections in your voice. They pick up the tough edge on things you say. And there's nothing better than to hear that, and you can try to correct it. All right? So, morality, you can't do anything about your morality, but just know it may impact how you deal with patients. And the stronger you are in those moral beliefs, the more they can impact. So I had a colleague years ago. I worked for many years in the state hospital. And I was in charge of the diagnostic clinic. It's a fancy name for admission. Police dragging in people night and day into the hospital. And I had a nurse I worked with. She was a wonderful psychiatric nurse. But she had a long history of alcoholism in her family and a lot of very negative outcomes from the alcoholics. She had been abandoned as a child, went into foster care, went into nursing eventually and had to work constantly to get the tuition to just get through, and on and on. She could not deal with older male alcoholics. And I knew it was her father. I knew her that well. And she had tried to rise above this through getting help. And finally, her therapist, who was a nurse, said to her, "You know what gets to you. You're never going to rise above it. It's going to be a hang-up for your life. Maybe with time, you'll let it go. Just don't take care of those type of patients." And she handled it that way. There were always at least 2 on duty in the diagnostic clinic because of the nature of the patients. A lot of them were assaultive. And if a elderly or middle-aged, 60s, 70s, alcoholic man came in, she'd say, "You take this one." I knew. And the other nurses didn't know, but they accepted that. She was wonderful with everyone else. When it got to people with those characteristics, it hit too close to home. And she was empathizing with family to the exclusion of listening to the patient, and it became obvious. But she knew herself. So that's morality. And it doesn't mean, and I think I've told you before, John F. Kennedy was a wonderful man. When asked if his Catholic background, because he was the first and only Catholic president, when asked, there was a lot of fear that the Pope would rule the United States if he got in. And people said it. He said, "Listen, what I choose for myself is my business, not the government's. But I believe the pathway should be open for every American to do the same, choose for themselves." And that's how you have to put your religion into your professional context. So morality is the religious or social beliefs, and there can be just as many moral teachings through your ethnicity, your background, your national origins. Although they are easier to get rid of, except the appearance maybe. They're easier to get rid of, whereas religion, at least in the Catholic Church, we have this specter of mortal sin, and you're going to burn in hell if you do certain things. That's with Catholics. I think Protestants and Jews and even Muslims are less radical on this. The Catholic Church has fed on hell and damnation for years. So to many people, even the most educated, this will sweep them in. All right, that's morality. It's different from ethics and different from the law. Let's look at the law. Someday I'm going to pull off that. Let's look. Oh, what happened? Nobody told. The law. The law in a democratic society consists of rules for social interaction defined by the people. You may not think that the laws and rules and regulations were defined by the people, but we've gone over the process. A bill becomes a law. How does a bill get in the hopper? Through a legislator that has been connected to a constituency. A bill becomes a law. The law goes to the executive branch for rules and regulation development, and the rules and regulations go through hearings. If you know where to go, you can find out what hearings are happening currently. All of this is done to define the law according to what the people want. It's defined by the people, promulgated by the government, which is established by the people, and obeyed by those people subject to consequences. The law exists because if we didn't have law, we'd be operating like a bunch of animals. Watch Channel 13 News. I don't know if you get 13. I get 13. New Jersey news. Every night is full of homicides, robberies. I hope too many people out of New Jersey don't pick it up, or it might be just as bad in Wisconsin and every other state. But there have to be laws, or we're a bunch of animals looking out for ourselves. And we live in a representative democracy. That's what we live in. So laws are the invaded. The third issue is ethics. And ethics is a free, rational assessment of a course of action according to principles. We're going to study those principles, or you might have read them already. There are a finite group of principles according to which you should live to be ethical. And you exercise critical, rational judgment in decision-making. Ethics is what ought to be, and in order to be ethical, you have to have a high level of intelligence. So, people are obliged to be legal. You have to be legal. They can be moral. It all depends on the culture and how strong religion is in your life. It does not necessarily make you a better person if you're attached to formal religion. Except when you get to the last day. I have 2 friends dying now. And that's a funny thing when you'll someday have friends that die. But these are people who are talking to you. They're not unconscious. They're recollecting what things you went through together. Yet they're dying. And I see, the old saying, everyone wants God when they're in a foxhole. You've heard that? Well, these people were not religious people, they were good people. And I think they were particularly good because they were nurses. Took care of the sick their whole life, were wonderful people, but have become very religious in the last few months. I never saw them with a rosary bead. All of a sudden, the rosary beads are laying on the bedside table, and they're praying. So as you get closer to death, if you have a religion, it's comfort. But organized religion, and if you want some thoughts on that, read Erickson. Did you all study Erickson in Lifespan? He's a developmental psychologist, and he's the one that identifies critical learnings for each era. Like autonomy is something that starts as a very little child when you're being toilet trained. This sounds crazy, but when you realize that you have the right to go on the toilet or not to go, and you're more or less forcibly taught to be autonomous to go on the toilet. And he gives certain qualities you develop in every era. And he calls religion a device to control the masses. I don't know what Erickson's persuasion was, if he was Catholic, Jewish, Protestant, I don't know, but his writing is beautiful. Erickson, E-R-I-K-S-O-N. He's a Harvard professor and very well written. Some of his books are very small pocket books. I'm suggesting to you it would be a good exercise. How many of you have heard of Erickson? All right, some more than I thought. All right. But he describes religion as a device to control the masses, and I never thought of it till then. He says that a religion involves a bunch of precepts that you take to heart, and it's a way of treating your fellow men humanly and fairly. And it goes past the law, and it does go past the law, but you need a lot of intelligence to be able to select the ethical principles that you're going to apply in different situations. It takes critical thinking, and ethics is what ought to be. So, the law is what you are obliged to do. You can be moral if you want to be, and you can be moral without being religious, though. But you must aspire to be ethical. All right. The whole practice of ethics is based on the work of select developmental psychologists. And you should have had this, or at least been introduced to it in growth and development, lifespan. So I'm not going to dwell over it. But one developmental psychologist is Kober, and he talks about the growth of personal moral thinking. And you'll find in the literature the use of the terms moral and ethical often interchangeably. I don't use them that way, and you're going to have to get used to that. To me, ethical is ethical. Ethical is choosing principles to apply consciously through critical thinking, and it's a step above religion and a step above the law. You're going to find situations in your professional life that are illegal, but you feel they're ethical. The ethical principle is higher than the legal. All right, one example, and I did give this to you weeks ago, with reporters and their sources. How many reporters have gone to jail because they will not divulge the identity of their source? Because legally, it says you have to disclose this. The reporter says, I gave my word to this person. I must honor that confidentiality, which is an ethical principle. And they've even gone to jail because of this. Now, of course, if a person gives you permission to share, that's something else. But in most of the cases that I've heard over the years, and from time to time you hear one, it's a situation that the informant doesn't want their name shared, all right? And we talked about, last week I believe, about the legal situation of privileged communication. Certain people have privileged communication. Nurses do not accept. There are more and more court decisions supporting privileged communications for advanced practice nurses. And some psychiatric nurses have been given the right to privileged communication through the courts, given the work that they do and the fact that it would be non-therapeutic for the patient to go spreading their information all around. So Kohlberg is the developmental psychologist that is the most basic work about moral or ethical thinking. And he talks about 3 stages of man. The pre-conventional reasoning, that's when you can't hold ideas in your head. You have to hold them in your hands. There are many psychologists that have this same frame of reference. Piaget. Have you heard of Piaget? He's my favorite. All right. Piaget, although I don't know today how much validity there would be to his theory. You know, he developed his theory looking at his own 3 kids. That's how he developed this theory, but he's right on when you look. Pre-conventional is when you have to have something in your hands in front of you. You could never conceptualize the idea of confidentiality. All right? Conventional reasoning is when you are starting to put thoughts together in your head. You don't have to have everything in your hand. And post-conventional is indicative of ethical thinking. Enough for you to know that in developing ethical behavior and ethical thinking, you go from a stage where you can't hold the concepts in your mind, you have to see them, to a point where you're starting to hold them in your mind, but then you get to a point where you can take a concept that and apply it to a new situation that you had never seen it in. All right? And there are others which have similar one interesting difference here is Gilligan. And Gilligan talks about women in moral and ethical development and claims that women develop differently. And if you're interested in this, I would go to Gilligan's work. Noddy is a disciple of Gilligan's. And both of them see women as defining morality or ethical behavior in terms of caring and avoiding hurt. Women see infliction of hurt as selfish and immoral. The studies that these principles are based on are old now. They're 50s, 60s, 70s. I wonder if you would see the same processes today with women beginning to break through the glass ceiling. You know what that is? Ascend into administrative positions, not to the extent of men, but, and we've lost, you know from one of your slides there, I didn't dwell on it, but if you review them at all, where our earning power is down to 71 cents about 2011, from 84 cents of a man's dollar, women are losing economic ground. So I'm afraid for the women in the room, it's going to be a constant battle, and that's why you have to be careful what you do, because you're acting for all women, not just for yourself. And for the men in the room, I wouldn't want women working side by side with me who felt they could get away with less than me. And that is a reality. Why is 50% of the Army nurse corps? It was at least a few years ago, men. Why? Nurses don't go out into the battlefield like the Crusades, with their equipment on their back. The medics go anyway. Why is half of the Army nurse corps men? And a very good career. But it's interesting. And 71 cents for the man's dollar when most women work just as hard. Job is a job. All right. In ethical decision-making, you're going to find a very definite time sequence. You're going to find ethical decisions that have to be made immediately, others that allow you some time for reflection, and then deliberate ones where there is enough time for you to gather information, think, and consult with other people. And that is usually the type of ethical decision-making that is made through an ethics committee. Every healthcare organization approved in the state of New Jersey has to have an ethics committee. In some cases, like with nursing homes, there may be an organization that shares one with a sister organization that's close. But every hospital must. There's no option about it. Why? Because there are constantly evolving questions that administrators do not have the answer to, and neither do the providers have all of the answers. There could be legal implications, there could be personal, ethical implications. The frameworks for ethical decision-making are primarily two, and these are the broad standards. And deontology and utilitarianism. Now, what does this mean? Deontology is when you base your ethical decisions on absolute standards that never change. Theos, it comes from the word God, it's inflexible, but it doesn't necessarily mean a religious framework. Just means that you never bend. Abortion is always wrong. It is always wrong to give a dying person who is in pain enough morphine that they don't feel the pain. And I could think of, there are a list of provocative situations at the beginning of this chapter, I think. Read them over. Ask yourself, what would I do? Deontology and flexibility, there's a standard, and it does not change as the situation changes. Utilitarianism is situational ethics. The end justifies the means. I used to have a priest come into this course to discuss ethics. He was magnificent. He died this year. But he was chief of ethics for the archdiocese. And he was the most broad thinker I've ever known. And he would say that it's the weak people that operate under a deontology framework because there's no decision to make. Black is always black, white is always white. There's no shades of gray. Utilitarianism is different. You have to look at the end you're trying to attain and ask yourself, do the means justify this? So it's always gray. Or like lawyers, the best ones I've ever known will say, no matter what you ask them, it depends. I can never tell you if you're going to win this case. Is the kid going to be successful in a pretrial intervention, not going to jail for something he did? Or is there going to be a stiff penalty? It depends. And all of this depends. So those are two very broad frameworks for ethics. Now there are ethical principles from which you pick, and it's critical that you understand these, and they are in your book. They're in your book from 191, if you have a book. All right? No, I'm sorry, from 189. Just make sure that you're conversant with them. They're, in the broadest sense, the ethical principles that will help you to decide. They're not legal, they're ethical. And in a situational ethics, in a situational ethics situation, you can make a case for these in 100 different ways. Autonomy. We've talked a lot about autonomy. The autonomy of the profession, the autonomy of the nurse, once you have a license in your hands, for making clinical decisions which should stand on their own and not be influenced by any employer. Except, no, I'll leave it that way, not by any employer. You may ask your colleagues for counsel in making decisions, but it should not be a factor involved in employment. Autonomy is the responsibility of the healthcare professional to accept the uniqueness of the patient. You will have plenty of patients you would not choose to have dinner with, can I tell you? You'll have plenty of patients who really turn your stomach talking to them. And I don't say you have to go into counsel to try to get on top of that. Accept it. You would not choose this person to be a friend, but he has the right to be what he is, and you have a responsibility to accept it. And you have to ask yourself, why am I taking care of him? Where did this thing jump off here? You really want me to use it. But the person has the right to the freedom to be what he wants. It is recognition that a person's purposes cannot be abridged because the person does not agree with you. In other words, a person who has made the decision to give up any future treatment for their cancer, every hospice patient is that person. All right. They've formally given up the right to future treatment. That deserves a minute's talk here. You know the difference between palliative care and hospice, do you? What is it? Come on, talk a little. What is the difference? Palliative care and hospice. Do you know? Go ahead.
It's like, it's not the institution, people feel like more comfortable, like they
a non-place. That's probably what. It's a non-place community. It's a program. It includes acute care, long-term care, home care, whatever you need. You're right. But the heart of the difference is that hospice, you have accepted the fact you're going to die in a certain limited period of time. I'm waffling on that because it changes from time to time. It used to be 6 months. With the government, it's still 6 months, but who can say you're going to die in 6 months? Who really can say? All right, and so some patients go on hospice and are then taken off because they don't die in 6 months. But hospice removes any right to curative care, any right. And let me say that loud. And the person has to hear that. No more cure. Palliative care allows treatment for cure. Allows treatment for cure. It's in New Jersey, under Medicaid, which is the program for the poor and the one we have the most direction for what is palliative care in New Jersey, you cannot get homemaker care to come in during the day if you're on palliative care. And you can have treatment for cure. But the aim of palliative care is to make you comfortable, which usually is removal of pain and removal of isolation. So that there is a very big attempt to network in those community groups and organizations that you had some association with. So the goal is comfort and caring with palliative care, comfort and caring. Give you enough drugs so that you're not in pain, make sure services come in, but no daily paid services. That's hospice. And so a lot of people, I had occasion to talk to our friend again, the thanatologist from University Hospital, mentioned her a few weeks ago. And she said, well, we have a lot more people on palliative care because people in the U.S. don't like the D word, death. They have problems coming to grips with death, whereas other cultures do not. But we don't. So they want that edge there so that there can be some cure if something surfaces in the interim. All right. But autonomy means I do not have to change myself because you don't like what I am. I am what I am. And you, as a caregiver, have to make allowances and accept me. This is particularly important when you have to act for a patient. It's frequent you have to act for a patient. If they cannot act for themselves, you will act as they would choose autonomously. That's a hard thing for nurses to do, and it's a hard concept for nurses to keep in front of them constantly. You hear what I'm saying? Patient needs something. You know what they would want, but you don't want to do it, so you do what you want. No. Whether they're conscious or unconscious, you do what they want because they are autonomous. Justice is the obligation for you to be fair to all people, to treat each equally, regardless of race, sex, ethnicity, medical diagnosis. So you're all thinking, well, of course we do. No, we don't. There have been many studies, and most of them done in New York, of nurses who care for victims of AIDS. I shouldn't call them victims. They get mad when you call them that. They're not victims. They're people with AIDS, all right? But there have been many studies showing that nurses make moral judgments on many of these people, which is unethical, absolutely. So justice says we're going to treat all people equally, and another interpretation is that we will give the greatest benefit to the least advantaged. And this is called distributive justice, very important. Give the most to the least. I think I mentioned to you, God knows how many weeks ago now, but it's a perfect example of distributive justice. Of the maternal child health statistics in New York City were at one point in time, about 10, 15 years ago, absolutely gross in Harlem. Now, Harlem now, an address in Harlem is a premier address. The work that has been done in that section of New York and the upgrading of businesses and facilities. But at one time, it wasn't so great. And there was dramatically a statistically significant higher level of maternal death and maternal morbidity and infant death, low birth weight babies, etc. in Harlem. So the city of New York invested a dramatic amount of money from their Medicaid program in Harlem, much more than in any comparably deprived area in New York. The Lower West Side was, until its recent gentrification, a very bad area, but they dumped the money into Harlem. And within about 3 or 4 years, Harlem had maternal child health statistics equal to the rest of New York City. And there were a lot of people who took exception with this. Why are you dumping the money in Harlem? Is it to get the political play? Is it because of the ethnicity of the people there? It wasn't. It was distributive justice. Distributive justice is giving the most to the least, to level the playing fields and to bring them some justice in. And this could be in police protection, it could be in health, it could be in anything. It could be in access to education, etc. But it's giving more resources to those that have the least. Freedom. Freedom springs from autonomy, and you will find some of these are related. And what freedom says is a patient does not have to deliver their agency or will to the doctor or nurse. Now, this is an ethical principle that has become forged in law. This is one of the basic principles underlying managed care. All right? You do not have to say, doctor or nurse, I'll do whatever you want. There are some people who eventually do. When they get so sick or they're so near death, I've seen many of them say, I can't make a decision. You make it for me. All right? It's important you reiterate what they're saying. Are you saying that, first of all, why do you say this? And then, are you saying you want me to make decisions about the medication, about this and that? Yes, I am saying that. I'm too weak to even think. And let's be realistic. I believe my time here is limited. Just make me comfortable. That is not the usual answer of a person who is not in active dying. If a person has wanted to call the shots all the way, that is a behavior you see in someone who's coming very near death. But freedom, you don't have to give your agency or your ability to act over to a doctor or a nurse. So freedom not only recognizes the individual's right to be told about what will happen to them, but to consent and to take back their independence whenever they want it. And it's related to autonomy, having the right to act as you want. Veracity. What do you think that means? Veritas. What? Truth. Yes. Veritas is truth. What's truth in, let's say, Spanish? Bet you somebody here. What's truth? What? Well, that's not. Sometimes you can see from the stem, what it is. But this is based on the Latin. Veritas is truth in Latin. And what this means is you have an obligation to allow yourself to know the true nature of your patient. And there's a linkage between all of these. To know what your patient is, to be confronted by the ideas and the freedoms that your patient would choose. And in veracity, there is another concept hidden in here, and it's very useful to you in getting to know your patient better. External or internal locus of control. Have you studied that in any of your other courses? Locus of control. It means, are you driven by the external environment, or are you driven by yourself? Your convictions that you hold in yourself. Internal or external locus of control. It's one of the points that I feel a nurse has to analyze about their patient, because now most people are somewhere in between, not an extreme internal locus or an extreme external locus. But if you have an internal locus or an external locus, a strong one, you give care differently. And there are things you can ask, as simple as tell me about yourself. When you come on a decision in their past, ask them, how did you make this? Did you ask other people for their opinion? And there are ways to determine if they're driven internally or externally. And that's very important in determining what truth is. For instance, a dying patient who tells you an internal locus probably wants to retain their ability to decide for themselves as long as they can. You know that drugs will cloud the sensorium. In other words, cloud the way they see things. They won't be able to judge internally as easily. They'll become confused. So, with pain relief, it's up to the nurse to determine what control that patient needs. And one dying patient I'm currently involved with, very internal locus. She makes her own decisions, and just said 2 nights ago, it doesn't make any difference anymore. I don't want to feel the pain. You do what you want. And she was letting that locus go. She was letting go what was her ultimate self. So she's getting near death, very near death. These things are sad, but they're also opportunities for you to give better care. All right, privacy. The right to be protected against intrusive contact. very simple. A person always has the right to privacy, and you see how all of them link together in a way. They're different aspects, many of them, of autonomy. In the hospital, and I hate to go back to the hospital because, again, I hope no more than 50% of you ever go to work there, but, or in home care. Once you're sick, you give up your privacy. And it's not right. It's like you give up part of your humanity. Always remember that. A person should never be laying in a bed exposed. You never have the right to invite other people in behind the drawn curtains unless the person says it's okay with me. You can tell the ethical nature of your practice by how you take care of patients. I can go in and, I've been around longer than you, but in a few minutes you can tell whether a student or a young nurse has ever been schooled in ethical principles. If they're washing up a patient, which usually aides do today, but if you find, or you went in to do an assessment on a newly admitted person, you pull back the curtain when you're finished and yell for the nurse's aide to come back in. It's not the way. Would you do that in your own home? You leave the patient often hair covered, and the patient is groping to pull up the covers. And these are things you should teach nurses' aides to. They're not that, it's difficult to practice, but it's not that complex to understand. Confidentiality, and we said linked in here is the concept of privilege, which you have to be able to sort in your mind, and it's the duty of the healthcare provider to protect the secrecy of patients' information, no matter how it's obtained. Maybe a mother doesn't want to know that her kid was taking narcotics. It's something you may put in the record, but you have no right to share it with anyone that doesn't have access to that record. Beneficence comes from Bien-aime, and beneficence speaks to the quality of your interaction with the patient, that you should always do good to those under your care. Beneficence is always doing good, and the next one, malfeasance, is in many ways the opposite of beneficence, do good and do no harm. Non-malo, do no harm. Non-malo, do no harm. Bien-aime, beneficence, do good. Pour that in your brain, even if you're not articulate in one of the Romance languages. Bien-aime, do good. Non-malo, don't do bad. And they are different, and you'll find clinical situations which bring immediately to mind the difference between these. A sub-concept under non-malo is justified paternalism, and it's here written down, but it's a sub-concept under non-malo, non-maleficence, do no harm. Justified paternalism is when you do something for a patient under the guise of taking care of them. Justified paternalism. You're not their father. You've got to hear it from them. Now, one situation where this comes up is in using restraints for a patient. A person in DTs, an elderly person who has lost some of the cognitive ability, who use restraints so haphazardly to protect. And it turns my stomach. You know, I told you about the Veterans Home in Paramus and their untidy environment where most of the beds are on the floor, and they purposely bought 3-inch mattresses, foam mattresses, and they put them on the floor. If you're going to fall, they figure how much you're going to hurt yourself with 3 inches, and they'll shut the door, but never that you can't get out. What does this mean for the nurse? This means you got to be on your feet, and you got to know what your patients are doing, and you can't go to sleep at the nurse's station. I hate to tell you that's your job, but I'm not just being glib with that statement. A lot of times on hospital or nursing home units, you'll find aides who work several jobs, and the night in places like that is an opportunity to get your rest for your day job. You can't do it. But justified paternalism, I would say occasionally it is justified. But you would have a tough case proving that to me. All right. There's nothing worse than a person who has been self-sufficient, who has been very independent their whole life, being restrained for their, quote, own protection. You see that frequently in nursing homes and in psychiatric facilities. Fidelity is faithfulness or loyalty as a part of practice. The basis for accountability. Fidelity, accountability. I gave you an example of non-professional conduct last week when a nurse comes in and finds out that there is not enough staff to give the type of care she wants to give on her shift, and says, I'm not taking overcharge, I'm leaving, I'm going home. It's a breach of fidelity. No matter how you cut it, if you have to make certain therapeutic actions your priority and not even consider even changing bedclothes. Give skeletal care, but you never have a right to abandon, and that's a violation. It's a violation of the law too, but it's a violation of fidelity. All right. Do you understand these few principles? All the others evolve out of. Those are the main principles that you'll be working with in your practice. Any questions about any of them? No? Okay. Your behavior should be determined by the code of ethics. And the codes of ethics are in your books. They're so vague and so amorphous, non-specific, that you couldn't challenge them. And they have been authored and promulgated by ANA and ICN. ANA, the American Nurses Association, and ICN is the International Council of Nurses. Especially ICN, remember that ICN is the voice of nursing in the world. There are formal nurses associations in about 160 geopolitical sites, and there aren't too many more countries. Almost every country has evolved a nurses association. In a few countries, they're under the control of medicine, which ICN says is a no-no, so they don't even let those nurses association become part of ICN. but they promulgate the codes of ethics. They're written very vaguely because they have to apply to practice all over the world. And in some places, very few, no, I'd say we're the most educationally advanced country in nursing. But there are some countries that are beginning to be our equal. Japan, definitely. Thailand, now. But Thai nurses, the Thai government was very generous and sent many Thai nurses here to be schooled up through their doctorate with the expectation they'd come back there to work, and they did. All right? So Thailand is very progressive. South Korea, I think you would need other qualities over there right now, but South Korea, very progressed. Their own doctoral programs. So they would understand even the most complicated code of ethics. But to appeal to every place in the world, ICM is very vague in general in their code of ethics. Read it, you'll see there's not much you can take exception with. And you see those principles running through it. The patient is autonomous. You should never do harm, always do good, and on and on. Competences ought to be maintained. You're to work fruitfully with other members of the healthcare team, and on and on. Very general, not much you can make exception with, although the code of ethics is revised or at least reviewed every 5 or 10 years. Then in addition, if you go into nursingworld.org, that's the ANA's website, on the left there is the position paper hotline. You click on that, there's a list in your book, but you'll find the full text of all the position papers, and they're based on the principles we just looked at. So if you're wondering what is ethical end-of-life care, click, there's a whole set of position papers, and they've been vetted through experts in the field. They may sound simple when you read them, but if you think a little more, they're not simple. For instance, the professional with AIDS or HIV positive should not enter into any type of nursing where there are procedures that take you deep into a body cavity and have you working with sharps. Period. ANA does not believe the government should get involved. That we're professionals, we will monitor ourselves and such things. It believes that when a person is near death, they should not have pain. We've said this a dozen times. But if you have to give so much narcotics to give them relief that it shortens their life, your aim is the relief of pain, not euthanasia. You understand? And if while you're relieving the pain, the effect is the depression of respiration, that's a common side effect of narcotics, you could not help it. Bien-aime, you were doing good. You were helping, no one should die in pain. All right? All of these are written down as position statements, and if you ever go to court on a case where one of these things is being looked at, the position statements of the profession drive the situation. A judge will look to you to bring the position of the profession and know that you have followed it. A common resource is the interdisciplinary or the Nursing Ethics Committee. We said that there has to be a an ethics committee. in every healthcare institution, home care organization, etc., where primarily the work is dealing with decisions around death. And when the case gets to the committee, I'm wondering why they're bringing it. The person's been on a respirator with no brain activity for a month, and they're bringing it to us, to the ethics committee, to know if they can turn off the electricity. I mean, that to me is immoral, that they have to ask this. They're stupid, the rest of the people, it's always a doctor in charge, you know. The doctor doesn't want to get sued, that's primary, and they're afraid that the family will become livid and sue. And I'm thinking to myself, did you talk to the family all this time that this person was in the state? Did you seek to have someone appointed guardian? And remember, the court termed this guardian ad litem, temporary guardian, or a family member as the permanent guardian. They can make these decisions. You don't have to bring it here. But there's a lot of fear in the healthcare community about legal suits. That's at the top of their mind. And ethics rounds are wonderful. They usually just occur in medical centers, but they have them at Robert Wood Johnson. They have them at University Hospital. You should, when you find yourself in either one of these facilities, and if you're interested in these type of things, ask, when do they have ethics rounds? Make sure you get there. The most frequently experienced issues in nursing practice. There was a study done a few years ago, and I would love to replicate it. Maybe that's how I should use my downtime, all right? Done with practicing nurses. And the most frequently experienced issues were, and we're not here to criticize the research. You can go to Dr. Yarachevsky. I'll send her the study, and she'll rip it apart and put all sorts of doubts in her mind. But I really love it. But the most frequently experienced things, nurses said these are the things that come into my life most often. Protecting the patient's rights and human dignity. I think we've talked enough about that. You know what the patient wants, but the family can get in your way. You don't handle that by coming to blows with the family or taking it to the mat, as one of my sons would say, bringing it down to a shouting match. You work, essentially the family becomes your patient. You work with the family to get them to the point where they trust you, where they're willing to listen to you, and sometimes the family can't take action themselves. It would be too painful. So you do what they can't do, or have someone else do it. But you don't ignore it. By working with the family, you're protecting the patient's rights and dignity because you know what they would have wanted. Informed consent and we reviewed that, what types of information the patient has to have to be informed. Providing care with possible risk to the nurse's health, a big one. Realize that you're at the baby steps. Next year you'll get into clinical, right? Next year, hopefully. Nursing is a psychologically stressful, very intellectually demanding, and very dangerous field of work. Why do you think I emphasize getting the patient out of the hospital? I've mentioned that many times because hospitals are dangerous places, and you're right in the middle of it with staff and HIV, and every multi-drug resistant TB. Those are probably the three biggest challenges to you as an individual, but they're floating around you constantly. And you do build up a resistance, but it's still a constant threat to you, the care that you're giving. And staffing patterns that limit patient access to nursing care, one of the other things that nurses are coming up against constantly. Now, despite all that they're reading this on a daily basis, there are the ethical issues that are most disturbing, bring on moral distress for the nurse. And moral distress is a common occupational injury. But most nurses don't realize that they're even distressed, all right? When you are suffering moral distress, you can't make a decision properly. You start to criticize your patients and become sullen with them. Oh, I hate those nurses. Go take a vacation. You start to snap. You start to say things like, we've gone over this 100 times. Can't you understand? And they look at you with their big eyes. All right? You suffer moral distress. But these are the most disturbing situations. Patients and family who are uninformed. And when you are told, I'll add to that, you are told not to inform them. Be careful of that agreement. Doctors will frequently say, and I don't want them to know anything about this. You've got to take that conversation a little further. Tell me about that. That's unethical. Tell me about it. Why? Well, they could never accept that she's going to die, but she is going to die. What about if I give the family some extra care, or better, if I call the psych clinical specialist and see if she can invest in them? Most providers are willing to do anything to get themselves out of the situation. Prolonging the dying process with inappropriate measures, the most disturbing situations. And that is definitely linked to not considering what quality of life is for the patient. Implementing managed care policies that threaten the quality of care, like discharge in a certain number of days, regardless of the situation that the patient has to deal with, and working with unethical or impaired colleagues. I made that point earlier today. It says in the Practice Act, you must report your colleagues who are unethical or illegal in their practice. If you notice that every time Jimmy Jones comes out of the treatment room, he goes in, stays quite a few minutes, he comes out, and he's much different than when he went in. Then you pay a little bit closer attention, you notice his pupils are pinpoint. You've got to intervene with that. I think I would talk to my colleague first, but make no questions about it. You have to intervene, all right? And for more than ethical reasons, do no harm, non malo. You're doing harm to the patient by ignoring it. But legal issues, because they can take your license if they found out you knew something and did nothing. So those are the hardest situations. And there are other common ethical issues. We've talked about most of them. I didn't change this year, but in 2005, only 27% of the sample had executed living wills. There's the durable power of attorney and living will, the final directives, are only very occasionally executed. And and most of the studies have been with the elderly. But you're no different. You should have these documents. DNR, do not resuscitate, must be documented by a physician in the record. And a slow code is unethical. Now, do any of you know what a slow code is? Slow code? Hospice nurses are notorious at this, in a way, but nothing would be different anyway. The hospice nurse, the case manager, is frequently called by the family when a patient is dying, almost has died. And several of them have said to me, that's when I go for breakfast. I said, what? You go for breakfast? They said, yeah. If I go there, I'm going to have to resuscitate because the family has never come to grips with that. You understand? You do? Okay. So they joke about it, but they go to breakfast because they want to be sure the patient gets it. Now, this is not every patient, but a patient who has prayed for death, but also is very troubled because of the family's non-acceptance, and is under a significant amount of drugs, which makes them unable to participate in decisions at this point. Slow codes used to be a thing which was, I don't know how usual they are. I have not worked a shift in a hospital for a long time, so I don't know, but it's unethical. You settle these misgivings, these thoughts on death before. You don't take it in your hands to have a slow code. Let me tell you one more thing. You're probably aware that 12-hour shifts for nurses have become common. And I'm not going to discuss the safety. There's been a lot of research about whether a nurse can work 12 hours and still, at the end of that 12 hours, be able to make clinical decisions. Or is their brain like toasted and they just are going through the process of being there like a babysitter? That's another issue. But how do you get to know your patients if you're only there 3 days a week for 12 hours? And I know that discharge is very rapid today. Many people are not there more than 3 days, but there are some. And the ones that are there longer are primarily those that really need you to understand them. And with this rapid schedule, 3 days, you're off for 4, or work 1 day, off for 2 more days, whatever. It's very hard because change doesn't always take place within even a 24-hour cycle. It was much more possible to give good nursing care when you were there 5 days a week, 8 hours a day. Most nurses don't want to hear that. The best of hospitals, like Mass General in Boston, which is one of the best, I just happen to know they've done away with the 12-hour shift years ago. Every full-time nurse works 8 hours a day, 7 days a week, and that's 5 days a week, and that's it. No long days and then having many days off, but it makes sense. All right, we talked a little about transplants and gene research and the treachery it holds today if you don't give full information to your clients. I've gotten involved with a transplant patient yesterday, and I learned something that may be interesting to you. People that have transplants are put on immunosuppressant drugs. These are drugs which suppress rejection so that they won't need another heart, you know. And due to that, their general system is off balance, and they're very high risk for cancer. Now, once I was told that, we had someone interviewing for a faculty position who's a chief in transplant. It was very logical after I spoke to him, because I have this patient that has developed cancerous tumors all over his face, and he never put two and two together. But this is the result of the immunosuppressive drugs. It also suppresses your ability to resist cancers. Fascinating. Maybe not to you, but to me it was. And I hope that people are told that before they have a transplant, because it's like you're playing with another deck of cards now. And then I started to think of all the people I know who have died of cancer who had transplants. And then I got another idea for the drug companies. And they've already started, this nurse told me, to develop a line of immunosuppressants, which is not as suppressing as some of the earlier types, and they're seeing less cancers. But you can't switch. If you had a transplant 8 years ago, and you were put on the old drugs, you can't switch to the later ones. They're doing research right now, but they've seen bad results if you try to switch to less suppressive drugs. Fascinating, I thought, and then I was thinking of all the transplant patients I know, and most of them have had cancer of the skin. All right? Cancers that you were marginally going to be victim to in your life come up very quick because of the immunosuppressive drugs. And it tells me that nurses had better know all these things, because that would be a condition associated with cure that a patient should know about. All right. Talked about most of these, and now moral distress. Moral distress or moral outrage is something you're all going to suffer a few times in your life if you're human at all. Although some people can roll with the punches, and they are feeling people, but they can deal very much with the moral distress in these ethical areas. This is a response to an action believed to be immoral, but against which one is powerless to intervene. I think we can all, I'm sure you think better when I give you tangible examples. An action believed to be immoral, but you can't do anything about it. A patient who is very near death is suffering pain, and there's a decision to put them on very large doses of morphine. They may need it for the pain, but you don't believe they should have it because this patient has confided in you. She has undone work to accomplish before she dies. Whether it's to speak to a child for the last time, to wait until her sister gets here, she wants to see her one last time, and the medical establishment makes the decision because of her pain. They don't even consider alternate ways to help pain. They move with medication, and you know it's something that is immoral given her situation. And moral distress accelerates to outrage. But fear of sanctions prevents retaliation. All right? Okay. Any questions at all? And I told you, for you people that came in late, I'm just letting you go 45 minutes early today. So in case the rest of the people feel they're being gypped, you were notified. Any questions at all? We have time for whatever questions. Okay. So, a question, yes, and you answered that.
It's kind of off topic, but the patient that you said that had cancer, like, basically, what did he have? What was his diagnosis?
He had a transplant of a kidney 8 years ago, and did miraculously well. He was back to doing everything, and even cheating now and then, which is his nature. He's a very bright man, but not highly educated, and he missed, because people who are taking suppressant drugs for a organ transplant have to take like 15, 16 pills a day, most of them. Now this is changing. Drug companies are doing cutting-edge research, so when we bash the U.S. drug companies, realize that they need money to do their work, and they're also not going to do it for nothing. Their stockholders would say, keep churning out those immunosuppressants in India and bringing them in big barrels. People are taking them the heck with this problem. But he would cheat with a pill now and then, but has been doing good, has had no rejection in 8 years. However, a year ago, he started with squamous cell, which is one of the cancers. It's not the worst, but with squamous cell. And unfortunately, I think he picked the wrong dermatologist, but that's a whole other issue. But there was a crummy job of excising, so that he really has been disfigured, right? And they keep on coming. So with the people I talked to yesterday, they said there's no way to stop it except vigilance. If you're very vigilant, you can get a growth before it gets deep roots. So they can take it off with a procedure that's called the Mohs procedure. It's a new procedure which is minimally invasive, and they can get it off. And you might have to go more often, but it's worth it because of the cosmetics. But I thought, well, go on to the new drugs. But it was not the recommendation, and this man is an advanced practice nurse in transplant, but it's always worth a second opinion. That's my philosophy. But yes, it's the drugs. When it reduces your ability to fight off rejection of the kidney, it's also taking away the capacity you have to fight cancer, if you're covered. Okay, any other questions? All right, so I'll see you next week. I will say, as far as
I